Muito bem, então, boa noite a todos. Estamos começando de uma maneira diferente aqui o nosso encontro da ABRAMEDE, voltando para o Google Meet depois de algum tempo, né, Jule? Tivemos um problema com o nosso link no YouTube, infelizmente, mas não vai fazer com que a gente deixe de se encontrar. E a dinâmica vai ser um pouco diferente do que no YouTube, porque a gente está, na realidade, na mesma sala que todos. As perguntas vocês podem mandar pelo chat, que está aberto para comentários. E então, assim, bem-vindos todos vocês, a ABRAMEDE mais uma vez reiniciando os encontros do trauma, Jule, Gibbs, bom ver vocês de novo depois da nossa pausa de dezembro. E hoje a gente está contando com a Larissa Senna, que é R3 de Medicina de Emergência lá do Espírito Santo, da Multivix, né, Larissa?
Sim, obrigada pelo convite.
Bem-vinda. Sem mais delongas, que já estamos na nossa hora, mas é isso aí. Podem ir fazendo os comentários, então, no chat, tá, pessoal? Quer falar alguma coisa? Jule, Gibbs, bem-vindos.
Obrigado. Oi, gente. Boa noite. Tá sendo muito legal participar desse projeto. A gente recebeu um monte de mensagens, assim, muito inspiradoras, que reforçou a necessidade desse compromisso. Está sendo muito legal. Lembrar que esse espaço é principalmente para os residentes, então aproveitem esse espaço, compartilhem, venham participar ao vivo. E muito legal, muito bacana estar aqui. Vamos começar.
Eu vou dizer, porque não fizemos em dezembro, eu senti falta dessa aula.
Eu vou dizer que a Larissa, que vai fazer a apresentação do caso, a gente vai fazer como das outras vezes, né? A Larissa faz a apresentação do caso, e aí depois a gente faz a discussão do caso, e o Gibbs hoje vai nos presentear com a aula, então. Se tu quiser começar, Larissa, te apresentar, então, já pode, na sequência da tua apresentação, tu já pode...
Vou compartilhar a tela, e aí eu vou me apresentar. Tudo certinho? Tá todo mundo vendo, né? Bom, boa noite. Meu nome é Larissa. Eu sou R3 de Medicina de Emergência pelo programa de residência da Multivix, que fica no Espírito Santo. Espírito Santo, para quem não conhece, né, é um estado que fica no Sudeste e um estado muito pequeno. Então, vim trazer esse caso de trauma de face. Acho o tema trauma de face um tema extremamente complexo e difícil, né? Então foi um desafio montar, mas foi muito legal porque deu para rever bastante coisa, e a ideia é trazer para vocês tanto a questão do trauma de face, mas também um pouquinho do nosso programa de residência, para vocês conhecerem como as coisas funcionam e como é que é o nosso hospital, né? Esse é o Hospital Estadual Jaime dos Santos Neves. Ele fica no Espírito Santo, no município da Serra. O município da Serra fica na parte litoral. Nosso estado é um estado pequeno, é um estado de 78 municípios. Todos eles são cobertos pelo SAMU. A gente tem pelo menos uma unidade básica de ambulância, né, em cada município. Nos municípios onde a gente tem maiores populações, a gente acaba tendo unidades avançadas, e a gente também tem o aeromédico, que nos ajuda a fazer a transferência de alguns casos que são tempo-resposta. E isso nos ajuda a ter um tempo, né, de chegada do paciente na sua referência de uma maneira muito rápida, que a gente não tem muito hospitais gerais, a gente tem hospitais mais centralizados, né, no quesito cardio, trauma, e o Hospital do Jaime é uma referência de trauma. Ele drena cerca de 2 milhões de habitantes, né, dessa área metropolitana do Espírito Santo. Além disso, a gente também tem a chegada de pacientes clínicos, pacientes de gestação de alto risco, e a gente também tem o Centro de Tratamento de Queimados, que é estadual, a referência. Durante o Covid, a gente foi o segundo maior hospital em número de atendimentos. A gente chegou a ter mais de 200 leitos de CTI, quase todo o hospital, quase todos os andares eram leitos de CTI. Mas hoje em dia, depois que a gente passou, né, a fase do Covid, voltou ao normal, a gente tem cerca de 415 leitos, e desses 415 leitos, cerca de 50 leitos são leitos de terapia intensiva. E lá é onde a gente roda a maior parte da nossa residência pela Multivix, tanto na parte de trauma, quanto na parte de pacientes clínicos, CTI, cirurgia, enfim. Os pacientes que chegam naquela portinha da nossa emergência são recebidos na sala de choque. Na sala de choque, a gente ainda tem o atendimento feito de pacientes de trauma pela equipe da cirurgia geral e de pacientes clínicos pela equipe da clínica médica, que cada vez mais, né, tem tido membros que são titulados ou que são egressos da nossa residência de medicina de emergência. Nessa sala, a gente tem um leito preparado, mas pode também receber cerca de 2 a 3 pacientes simultaneamente. A gente tem ultrassom portátil para poder fazer ultrassom point of care. A gente tem no nosso andar tomografia, raio-x de tórax, banco de sangue, enfim, é um hospital com uma infraestrutura muito boa. E no andar da emergência, a gente tem também as especialidades que auxiliam no atendimento dos pacientes de trauma. Cirurgia vascular, cirurgia torácica, neurocirurgia, além da cirurgia geral e da medicina de emergência, e caso a gente precise de algum outro parecer, como a gente vai precisar hoje do pessoal da bucomaxilo, né? O nosso caso clínico é de um paciente de 20 anos que sofreu uma colisão moto-poste e ele foi trazido pelo SAMU no dia 18/8, cerca de 4 horas da manhã, e foi levado para a sala de choque. Na sala de choque, ele foi avaliado pela cirurgia geral, onde foi feito o atendimento inicial e foi visto que ele não tinha sinais de sangramentos exsanguinantes, que ele tinha uma via aérea pérvia, que ele estava em uso de colar cervical e que tinha uma queixa ativa de cervicalgia. Na avaliação de murmúrios vesiculares, eles estavam presentes bilateralmente, não tinha alteração da expansibilidade, ele saturava 94, tinha uma frequência respiratória de 30, tinha pulsos amplos, tempo de enchimento preservado, estava estável hemodinamicamente, porém ele tinha um rebaixamento do nível de consciência. Ele tinha um Glasgow 13, perdia em resposta verbal, estava confuso, e ele perdia um ponto também em resposta motora, apesar de ter pupilas isofoto. Na avaliação externa, a gente viu que ele tinha uma ferida cortocontusa e supercílio, tinha edema periorbitário, principalmente à esquerda, e ele tinha um hematoma, né? E associado a muito efizema subcutâneo em face. Foi solicitado os exames, né, de tomografia pela equipe da cirurgia, eles solicitaram somente a TC de crânio, onde foi visto que ele tinha bilateralmente hematomas epidurais e hematomas subdurais. Não tinha um desvio de linha média e, por isso, a equipe da neurocirurgia optou por manter um tratamento conservador e manter esse paciente na nossa sala vermelha em vigilância neurológica. Essa é a tomografia dele. A gente consegue ver, né, que ele tem bastante edema, além do sangramento. E uma parte que chama muita atenção é que a gente vê as alterações em face, as fraturas faciais que chegam a ser laudadas na tomografia, inclusive, que apesar da gente não ter solicitado, né, da equipe de atendimento inicial não ter solicitado, é muito notório essa questão das fraturas de ossos da face. Bom, ele ficou internado na sala vermelha e ele estava apresentando flutuação do nível de consciência. Às vezes ele apresentava agitações, às vezes ele rebaixava. E na avaliação foi visto que a gente não conseguia avaliar todos os sinais de alerta, né, de quando a gente tem um trauma de face, a gente não conseguia principalmente avaliar porque é um paciente não colaborativo, então tinha algumas questões que a gente não conseguia fazer avaliação, mas a gente não achou a presença de diplopia, de alteração da acuidade visual, não tinha alteração dos movimentos oculares, não era visto nenhuma hemorragia retrobulbar e a gente também não tinha presença de nenhuma fratura cominutiva. Foi realizado uma tomografia de face para a gente ver melhor todas essas fraturas que ele apresentava. Ele tinha fratura de esfenoide com extensão para mastoide, ele tinha fratura de lâmina pterigoide, ele tinha fratura em seio frontal esquerdo que chegava a se estender à tábua interna, ele tinha fratura do seio zigomático, tinha também fratura de septo nasal, tinha fratura de órbita esquerda e ele tinha um extenso hematoma subcutâneo em hemiface esquerda, que era o que a gente conseguia muito claramente ver no exame físico dele. Foi solicitada a avaliação da bucomaxilo, eles avaliaram e que não tinha nenhuma conduta de urgência, que esse paciente deveria ser operado de forma eletiva. Essa era a reconstituição óssea, né, da tomografia dele de face. Após algumas horas na sala vermelha, ele acabou evoluindo para um rebaixamento do nível de consciência. Ele estava em Glasgow 6 e foi necessário intubar para que a gente pudesse proteger a via aérea dele. A intubação a gente optou por uma sequência rápida, com uso de etomidato e succinilmetônio, e além disso a gente se preocupou muito com a questão do double setup e do auxílio com o buge, porque externamente era muito feio e a gente não sabia quais eram as consequências, né, dessa fratura dele na questão da visualização da via aérea. Então, foi feita a pré-oxigenação com máscara de alto fluxo em flush rate. Não foi necessário fazer uma otimização hemodinâmica, o paciente não tinha nenhum sangramento, e tanto que o choque index dele era um choque index no limite superior da normalidade, e a gente se preocupou muito também com a questão da otimização, que a gente não sabia qual que era o Cormac que a gente ia achar, sendo possível até que a gente tivesse que evoluir para uma via aérea definitiva cirúrgica, por não conseguir visualizar muito bem pela laringoscopia direta. Na época, esse caso aconteceu foi no meu R1. A gente não tinha disponibilidade de videolaringo na sala vermelha. Atualmente a gente tem, mas na época, infelizmente, não era possível, senão provavelmente seria algo que eu teria pensado na abordagem da via aérea desse paciente. Essa imagem, infelizmente, não é desse paciente, que é o caso, mas eu peguei uma imagem muito parecida com a imagem real, né, do paciente, para tentar ilustrar como é que era a questão externa do paciente, e para a gente tentar entender por que foi visto que poderia haver uma certa dificuldade na realização da intubação, da abordagem de via aérea dele. Porém, quando a gente foi fazer a laringoscopia, algo que a gente achou que seria muito difícil, na realidade, era uma visualização muito fácil, porém é válido a gente se preparar com toda a atenção que era necessária, pois a gente não sabia o que poderia ser que a gente iria encontrar nesse paciente. Após a intubação, a gente fez a gente optou por repetir a tomografia de crânio, não foi vista nenhuma alteração do exame anterior e foi mantido em conduta conservadora pelas especialidades. Ele foi logo no mesmo dia para o CTI. Alguns dias depois ele foi feito a abordagem, né, da osteossíntese da fratura do osso zigomático, aproveitando para fazer também, no mesmo tempo cirúrgico, uma traqueostomia, porque ele era um paciente de difícil desmame, paciente muito agitado, que a gente não conseguia fazer no CTI um desmame para poder entubar ele da maneira correta. No dia 1º, ele foi reabordado, precisou fazer uma coleta, porque estava apresentando secreção purulenta em seio maxilar, e cerca de 1 mês e 15 dias após a entrada dele no hospital, ele teve alta com segmento ambulatorial, com a cirurgia torácica, com programação de decanular e com a bucomaxilo para acompanhar as fraturas. Bom, esse foi o caso clínico que eu trouxe para a gente discutir, e é isso.
Muito bom, Larissa. Ótima apresentação, muito obrigada. Exatamente pelo que eu entendi, é um caso de fratura de face, vamos dizer assim, quase que associada, obviamente, um traumatismo cranioencefálico, mas ele não me pareceu ter, em momento algum, trauma de tórax, ou de tronco, ou de extremidades. Não. É isso mesmo?
Ele tinha ATC de tórax, de abdômen, e ambas estavam sem alterações. Foi um trauma realmente direto em face.
Porque isso chamou atenção, isso era a minha primeira pergunta, na realidade, assim, eu vi que ele foi inicialmente atendido pela equipe de cirurgia geral, então vocês não têm cirurgia do trauma aí no hospital de vocês, é isso?
Não, a gente não tem cirurgia do trauma.
E a geral pediu uma tomo de crânio, e não a estendeu para a face cervical, mesmo o paciente estando estável, né, e isso é uma coisa que a gente tende a não fazer, a gente acaba fazendo junto quando o paciente está com uma certa estabilidade, porque depois a gente perde esse timing. E é importante, assim, se a gente tiver a chance de abordar a via aérea existia desde a chegada, né, e visualmente a gente via que era uma face complicada, um paciente que, pelo que eu entendi, não tinha sinais de estar se afogando em sangue, mas que eventualmente ia precisar, a gente tinha que estar preparado para ter que abordar essa via aérea, ia ter dor, ia ter que sedar, eventualmente ia ter que ir para o bloco, e era muito importante a gente ter uma ideia de como é que estava a cervical. Então eu vi que pediram uma tomo de crânio, que depois complementaram com uma tomo de face. Eu não sei se em algum momento pediram, pelo que tu está me dizendo, pediram um tomo de todo o tronco, sim, mas pelo que tu deixou claro na tua apresentação, isso foi depois dessa primeira avaliação que fizeram somente uma tomo de crânio, né? Então, se eu fosse ressaltar alguma coisa, eu ressaltaria a importância que se tem de ver e enxergar já adiante o que vai se precisar esse paciente, já pedir desde o início uma tomo principalmente de cervical ali, porque ele tem, obviamente, fratura de face, a gente tem que ver como é que está o neuroeixo, e são pacientes que a gente acaba fazendo tomografia de corpo inteiro, assim, se ele tivesse talvez um pouco melhor, eventualmente poderia se fazer no segundo momento, mas um trauma dessa magnitude, com a transferência de energia que teve, a gente tem que ter uma ideia se tem algum outro sangramento, a gente vai perder esse parâmetro no momento que a gente cede o paciente, né? Então...
Exatamente. Foi um trauma de uma alta energia cinética, era bem claro que o paciente tinha, né, um trauma direto em face, então realmente comeram bola nessa parte e deixaram a TC de face para um segundo momento. A TC de cervical foi realizada porque ele tinha até uma queixa ativa de cervicalgia, sem nenhuma alteração também.
Isso ele fez junto com a tomo de crânio, então?
Isso, no primeiro momento.
Ok. Não, isso já ok. Porque às vezes só essa primeira passada já se dá uma ideia do que tem na face, aí tudo bem se reconstruir depois, mas aí me preocupou o fato de eu não ter visto em momento algum uma tomo de cervical num paciente que ia ter uma via aérea complicada, né, então, enfim. Mas eu peço que as pessoas que quiserem fazer comentários e perguntas façam no chat. Eu já vi que o Dr. Gibbs quer fazer algum comentário. Fica à vontade, Dr. Gibbs.
Larissa, a sua apresentação foi excelente. Eu vou fazer comentário em inglês. So, difficult patient, and most of the cases that we've talked about that are coming from Brazil are motorcycle crashes. So just remember that. It's a very high energy, probably one of the most severe types of trauma, blunt traumas, are motorcycle crashes because they're high velocity, and we describe what's called unprotected trauma. So they're not inside of a car, so everything is vulnerable. I agree with Paula that if he comes to our hospital, every part of his body is going to be he's going to have a CT scan of his entire body. And I tend to fight the residents, by the way, because I think they get too many CT scans. But this is not a case to be a medical economist. You need to basically evaluate the patient from head to toe because of the energy transfer and the high potential for torso injury. So I agree with that. The other specific area that you need to look at are the vessels, the cervical vessels, to make sure that he doesn't have a vascular injury in his neck with that kind of blunt force trauma to the face. I want to say that your plan for the airway management was excellent, and I completely agree that having a bougie would be mandatory, and doing what you described as a double setup. If this patient were I just left the hospital, by the way. I would say if he came into my hospital today, we would do exactly the same thing. Bougie, double setup, etomidate and suctional choline is a good choice for intubation. And also the literature on video laryngoscopy, we just heard about concerns of cervical injury. Remember that there is very good research that if you hold the neck in line, so you don't allow the patient's neck to move, that video laryngoscopy is superior to direct laryngoscopy. So I would say this would be a case where if you have it, video laryngoscopy would be obligatory to make sure that you can actually enter the mouth without moving the neck and have adequate, effective visualization of the glottis. So that's a now that you have video in your hospital, I think this would be something that I would always do with video laryngoscopy. And also being prepared to do a rescue cricothyroidotomy, I think is very, very, very wise in a patient with this injury burden to the face, because you may not be able to open the mouth. There may be blood in the mouth, etc. And lastly, I really applaud your use of shock index to make decisions about hemodynamic stabilization. And this, as you point out, his shock index was 0.7. So I think that's a good signal that the patient is hemodynamically stable. Although I will say, without imaging in a motorcycle crash, just be careful. I would say just be very, very cautious, because the patient could have an injury anywhere, right? And that first hour is a very vulnerable time. But I would say your presentation was outstanding, and the management of your patient was excellent. Thank you very. And we would do things exactly the same way that you did. Remember, there's some evidence now that's more recent, not in trauma patients. There's some medical literature that's come out comparing etomidate to ketamine, and there's a signal that etomidate actually provokes less hemodynamic instability than ketamine. So I think we're moving. We liked I started with my career with etomidate. Then we moved over to ketamine a bit, and I think we're starting to move a little bit back to etomidate because of hemodynamic stability. So I think you made a wise decision in your drug selection.
Obrigada.
Excelente, Larissa. Parabéns pela apresentação. Não tenho nada a acrescentar. O Gibbs e a Ana Paula foram precisos. E agora, o Gibbs comentando, eu estava falando isso hoje com os residentes, né, sobre a decisão entre etomidato e ketamina, apesar que não teve diferença de mortalidade, pensando num trauma, né, num TCE, a hipotensão pode aumentar a mortalidade. Acho que faz mais sentido realmente a gente ter uma tendência para ir por etomidato nesses cenários, assim, fez muito mais sentido para mim agora também, esse perfil de paciente. Mas, enfim, excelente apresentação, muito boa mesmo. Muito legal conhecer seu hospital, sua cidade, muito bacana.
Eu acho que é muito legal nesse projeto que a gente consegue conhecer vários hospitais do Brasil e ver como as coisas andam, ver ainda, né, locais onde a gente quer chegar. Por exemplo, quem sabe um dia na nossa sala de trauma a gente consiga que os emergencistas façam um atendimento do trauma também, né? Eu acho que isso seria muito legal, é uma coisa que a gente gostaria.
Não só legal, né, Larissa? Eu acho que isso mostraria uma melhora na qualidade do atendimento e também de suporte para o pessoal da cirurgia geral, né? Porque eu imagino que a equipe de cirurgia geral do teu hospital funcione como uma equipe de cirurgia do trauma. Vamos pensar que eles talvez estejam fazendo isso há muitos anos e já tenham uma expertise no que fazem. Mas se eles são cirurgiões geral, né, e se eles fazem a cirurgia geral, não necessariamente só a cirurgia de emergência, ou seja, não só os casos de cirurgia geral que se apresentam na emergência, mas se eles têm seus consultórios e acabam fazendo outras coisas, isso tira o foco acaba não sendo a sua atividade fim, e ter uma equipe colada neles que ajude e que seja, assim, daí, especializada nesse primeiro atendimento, ajuda muito, melhor, dá um salto de qualidade lá em cima, né? Isso a gente vê acontecer direto, assim. Mas eu queria passar para as perguntas que a gente já tem, eu acho ótimo. Então, a primeira é sobre esse paciente, devido à cinética do trauma e alterações de consciência, haveria indicação de toma de corpo inteiro. Eu acho que o Gibbs já falou sobre isso, né? Foi justamente o que ele comentou, que esse tipo de paciente com grande transferência de energia, a gente acaba fazendo tomografia precocemente de todo o corpo. Eu fiz um comentário enquanto o Gibbs falava da comparação dos trabalhos desse último ano que saíram da comparação da ketamina com o etomidato. A gente tem 2 trabalhos com uma metodologia muito similar que mostram diferentes resultados, então, e com um grande número de pacientes, então eu até tenho bastante vontade de ver para onde vamos nesse sentido, assim, porque talvez não dê para fechar totalmente essa questão, né, e que é interessante, porque talvez a gente tem que ver o que fez com que eles tivessem resultados diferentes. Um deles é um trabalho brasileiro, o outro então do hemisfério norte, então assim, talvez realidades diferentes, pacientes diferentes, então fazer essa comparação talvez seja interessante. Depois o André também perguntou sobre trauma de face, nesse caso, haveria indicação de intubação precoce diante do risco de reabastecimento sensório? Ótimo pergunta.
Yeah, I was going to mention that is the timing of airway management in this patient, I think, is really important. And because remember that your patient has a GCS of 13, and he may have bleeding into the airway that you can't see if he has significant facial trauma. And the other thing is he's going to be flat on the CT table, right, and out of your care. And I would say the fact that he was intubated is no surprise given the amount of facial trauma that he had. And remember that his airway edema will worsen over time. So with that injury burden, if Larissa, if you and I were working together, and if you were to say, I think we need to intubate him now to keep him safe so he can travel to radiology, and let's do it now. He's early, he's not bleeding. The situation is okay. I would be totally supportive of that decision because we know he's going to look at a lot of imaging, and I worry about him aspirating on the CT table, or the airway becomes even worse over time because of worsening edema, and now you're really in trouble. So I agree with the decision. As you did, his monitoring was excellent. So your team monitored him very closely and then proceeded. But I agree with the question and the comment about early airway management is going to be essential. But remember that once you give him succinyl choline, you have to be prepared to do airway rescue, right? Because, for example, he would not be a patient that I would recommend a blind insertion device, like for example, an iGel or a combi tube. I would not recommend it in this patient because he has so much facial trauma. So it's either going to be, your choices are going to be pretty limited, and also endoscopic intubation may be difficult because of bleeding. So I narrow my choices pretty quickly. It's going to be videolaryngoscopy or surgical airway, and those are my two choices. And the one situation that is the most hazardous is if the patient has facial trauma and trauma to the anterior neck, and you're really concerned about your ability to do a surgical airway. Those cases, I would say, are terrifying because your options are so small. But you did a double setup is a perfect solution to this particular case.
É isso aí, eu concordo plenamente. Precocemente pensar em intubação.
E acrescentando, eu acho esse racional que vocês tiveram foi absolutamente perfeito. Então, é uma viéria cheia de sangue, pode ter hematoma, pode ter hematoma no subcutâneo que obstruía a observação. E, por outro lado, também, o trauma de face pode, na verdade, facilitar completamente a intubação, né? Que tira esse grande problema que a gente tem para intubar, que é o osso, né? A mandíbula. Então, a mandíbula quebrada, ela vai ficar solta, e aí você consegue laringoscopar, na verdade, com mais liberdade. Então, realmente é um tudo ou nada, né? E a gente sempre, claro, tem que estar preparado para o pior. E lembrar também que quando você vai fazer o resgate, se você for tentar colocar a guedel cheio de hematoma, sangrando, e a máscara do ambu em cima do rosto do paciente, se não tiver um teto, né, anatômico para a máscara vedar, você não vai conseguir pressão suficiente para resgatar o paciente. Então, você vai ambusar e o ar ele vai sair. Então, é justamente isso, né, esse preparo, double setup, então é perfeito para essa situação. Foi magnífico, muito bom.
Inclusive, eu vou aproveitar para já chamar a próxima pergunta, que é sobre o trauma de face e as indicações ou contraindicações para o uso de cânulas oro e nasotraqueais, caso fossem necessárias. Então, trouxeste aí esse glimpse já de uma cânula, e então a pergunta é sobre as contraindicações das cânulas oro e nasotraqueais no paciente com trauma de face.
So nasotracheal intubation, is that the question? Okay.
Cânula nasotraqueal e cânula de Guedel, na realidade, né?
Para resgate?
Isso, para resgate pra manter a viária pérvia, né?
O ambu, com a BVM.
So I would say you only go through the nose if you do under direct vision, right? So you can use an endoscopic assisted nasal approach, but I'm really going to try to avoid that unless I absolutely have to. I'm not going to do anything blind through the nose because you can get into a bunch of trouble. And we've all seen the pictures and books of nasogastric tube in the brain. I mean, it's just, you just can't do that. So again, back to the surgical airway being your rescue technique of choice. And as Julie mentioned, these patients can be very difficult to pre-oxygenate, right? Because you can't get a good seal with a mask.
É. Nós tivemos um caso no início das nossas discussões ano passado, que era um caso de via aérea até difícil e tal, e foi um trauma de face complexo. E eu lembro que foi no interior de São Paulo, não lembro quem foi o residente que apresentou, Jule, não sei se tu vai lembrar.
O que eu vi foi o da Nayara, da UFMG, que eles tiveram, era uma aula sobre via aérea, eu acho, e eles tiveram uma fratura de face muito grave.
Horrorosa,
Não
que
foi
ela
em Porto
encheu
Alegre?
de gás embaixo, lembra?
Sim.
A nossa foi via aérea e
tá.
teve um trauma de face. Mas ok,
Mas teve
foi
outra.
essa abordagem básica da via aérea, né? Mas teve uma segunda aula no passado, que era um trauma de face super complexo numa cidade do interior, que tinha que ser entubado, que o paciente estava lúcido, mas estava com a face destruída, lembram? Tinha até fotos do paciente. E ele tinha colocado gás, ele teve que remontar o rosto para conseguir ventilar o paciente, para conseguir fazer a intubação com segurança. Não foi difícil a intubação, eu lembro que ele fez esse comentário. O difícil, todo o mecanismo, a engenharia teve que ser como remontar a face do paciente para conseguir acoplar uma máscara, para conseguir ventilar e quando fizesse a intubação, eventualmente se precisasse ventilar, poder ventilar, porque o paciente não tinha como fazer nenhum tipo de ventilação de resgate. Foi bem interessante, assim, a maneira com que eles mexeram ali, botaram umas compressas, umas gases, tiveram que remontar o rosto do paciente. Então é isso aí, a gente precisa ter o cuidado de fazer um bom selo, né? Eu vou te dizer que isso é uma das características que faz com que a gente diga que é uma VL difícil, é a parte de oxigenação, tanto pré-oxigenação quanto resgate.
Sim.
Porque, como disse a Júlia, às vezes a visualização não é tão difícil, mas a gente vai ter dificuldade com a oxigenação. Fora o sangramento, né, que às vezes faz com que a visualização seja difícil e às vezes o paciente se engasga, aspira, uma confusão. O Ross está perguntando se existe algum comentário em usar ketamina sem paralítico como escolha para intubação no caso de um trauma de facial para limitar o risco de perda de patência da via aérea.
So I tend to be, I tend to have a little bit of a polarized opinion on this. If for example, Larissa, if your patient had very significant facial trauma and you were concerned about doing a surgical airway, right? So maybe the patient is massively obese or has a hematoma right on top of the larynx, and they have significant facial trauma, then you cannot paralyze the patient. You cannot do that because if you lose the airway, you don't have a rescue option. But if I walk up to the patient and their neck looks like my neck right here, and again, you and I are working together, and I know that you can access the cricothyroid membrane, I tend to go all the way with RSI. Double setup, equipment at the bedside for surgical airway. You've already identified the cricothyroid membrane. You know exactly what to do. It's going to be bougie assisted. And let's say if I'm intubating and you have the knife in your hand, I will get 1 or 2 tries to look in the mouth. And if that doesn't work, we go right here. Now, if you can't access the cricothyroid membrane because of trauma or severe obesity, then I think you're going to have to look with sedation alone, because if you lose the airway, if you can't intubate the patient orally and they have a neck that's not accessible, you're not going to have any other choice. But so I tend to simplify the world into surgical airway, yes or no. If I can do it, then then I will use neuromuscular blockade. If I'm very concerned about doing a surgical airway, then I will not. That would be a very, very uncommon situation where you're concerned about the inability to perform a surgical airway. Then I'm going to go ahead and use sedation only. Otherwise, I'm going to paralyze the patient 100% of the time because of the higher success, especially with video laryngoscopy. Your success rate is going to be so much higher that I'm going to commit, right, to neuromuscular blockade.
Algo que poderia nos ajudar também nesse paciente seria a questão da identificação da membrana cricotireoide pelo ultrassom, né, que a gente já deixaria ali marcado, e caso evoluísse, né, para uma necessidade de resgate por via aérea cirúrgica, a gente já saberia ali exatamente onde realizar. No caso desses pacientes, onde poderia ser um paciente um pouco mais difícil de conseguir identificar manualmente a membrana.
Eu concordo plenamente com vocês, e eu acho que uma dos benefícios, né, de você fazer só a ketamina é você tentar preservar, né, a via aérea do paciente e olhar, e aí tentar sentir mais ou menos se você vai conseguir a dificuldade visual mesmo da laringoscopia. Porém, num paciente sangrando ativamente, talvez você também não tenha esse tempo todo, né, para você fazer isso e aí, enfim, converter para sequência rápida, etc. Tá muito na moda a COBE, né, que é a intubação sem uso do bloqueador neuromuscular, mas o que a gente tem de evidência agora é que talvez a gente não sabe fazer isso muito bem. Quando a gente faz COBE, geralmente a gente diminui a taxa de intubação com uma tentativa só. Então, a laringoscopia fica mais difícil. Então, se eu tenho previsão de um paciente que eu preciso dessa via aérea segura, de uma forma rápida, que tem risco de ter uma via aérea contaminada, todas as complicações, por que eu vou tentar deixar isso mais complexo? Principalmente se eu não tiver essa habilidade, né? E assim, não parece que diminuiu complicação. Então, a gente não tem certeza se realmente é uma técnica segura que diminui desfecho e diminui mortalidade. A gente precisa de mais estudo. Não quer dizer que não se deva usar, mas a gente tem que ter essa noção de que a gente precisa adquirir essa habilidade de laringoscopia. Então, se eu estou ali no meu primeiro, segundo ano de residência, meus primeiros pacientes, então eu tenho que aprender muito laringoscopia, para daí, né, com bastante experiência, ter alguns pacientes que eu identifique que não seja difícil para eu fazer a técnica COBE, para quando for difícil eu ter essa habilidade. Foi exatamente o que a Ana falou para videolaringo. Eu acho que para COBE isso cabe muito bem. É um racional muito bacana, mas é isso, né? Você tem que ponderar isso. Eu também estou no time do Gibbs. Eu acho que a minha tendência é, se eu consigo fazer a via aérea cirúrgica, eu vou fazer sequência rápida, porque depois que você paralisa o paciente, a laringoscopia realmente fica muito mais fácil. E aí, se o paciente tiver uma via aérea anatomicamente difícil e não for possível entubar, ele desaturar, e a gente passa para o resgate com via aérea cirúrgica, né?
Não esqueçam que esse paciente tem uma dificuldade de pré-oxigenação muito grande. Então, o nosso tempo de apneia, ou o tempo, ele é um paciente que rapidamente vai desaturar. No momento que a gente der uma sedação leve que seja, vamos ketamina only, né? Ele vai fazer uma hipoventilação. Mesmo que não é importante, mas ele vai fazer. E a gente pode estar falando de uma pré-oxigenação que não tenha sido otimizada com uma via aérea suja. Talvez o melhor seja a gente se preparar precocemente para uma via aérea cirúrgica, e em alguns casos de trauma de face, a gente já falou sobre isso, os nossos casos de via aérea de trauma de face do ano passado, passar direto, escolher direto fazer uma crico não está errado, né? Dependendo do tipo de trauma que a gente tem, às vezes não tem o que fazer, né? Nós temos mais uma pergunta: qualquer serviço de emergência seria mais efetivo, dinâmico, com benefício à população, com atendimento integrado da cirurgia geral, do trauma e do médico de emergencista, juntos, em cooperação e sintonia. Todos cresceríamos técnica e cientificamente, não tenho nem dúvida disso. Eu tenho uma experiência, daí a gente vai falar, que é o que a Larissa falou, né? A gente tem diferentes locais no Brasil apresentando com diferentes realidades, né? Então, realmente, assim, eu venho de um lugar onde cirurgia tem cirurgia geral, tem cirurgia do trauma, e a gente tem emergencistas, nós trabalhamos juntos há anos e as coisas funcionam muito bem, assim. Tem lugares onde isso recém está começando e está se mostrando essa diferença, e em locais, talvez, onde tu trabalha, que ainda é muito separado e que a gente ainda tem muito a ganhar. Essa troca de experiência que a gente tem aqui, ela é muito importante para reforçar que funciona e que melhora. Então, eu concordo total com o Paulo, e acho que é isso que a gente tem que buscar. Não tem como atender trauma sem ser junto com a cirurgia, né? E eu acho que a cirurgia sozinha, ela deixa de usufruir do que a medicina de emergência tem de expertise para melhorar no atendimento daqueles pacientes, né? Então, a gente tem que trabalhar junto, com certeza.
Dr. Santos,
perfeito.
eu tenho uma pergunta para você, Dra. Santos. I think I heard you say that there now is enthusiasm for doing intubations without neuromuscular blockade in Brazil. Was that correct translation of what you said?
Yeah,
I would say,
kind of.
okay, so I'll be 65 next year. When I started emergency medicine, they did not let us use suctional choline. I was not allowed. I was not permitted to use suctional choline. I promise you that one of the biggest advances in, sorry, as my dog's barking in the background, of successful airway management was the use of rapid sequence intubation, and the success rates of sedation only are 85%, right? Versus well over 95%. So I'm going to be very, very selective if I'm not going to use neuromuscular blockade. And the other thing, Larissa, is if you do a surgical airway in this patient, you should smile. You should never be apologetic and say, "Oh, we had to do a surgical airway." Remember, his face is destroyed. He's going to get it. He's going to get a tracheostomy anyway. And if you save his brain by never allowing him to become hypoxic because you do a surgical airway right away, I will say, good work, right? Sometimes I think we are blamed for, they'll say, "What's wrong? Why couldn't you intubate this patient orally?" You should never believe that to be true, because you know his face is destroyed, right? So I really never hesitate to do a surgical airway if that is needed to save your patient's life. So I'll say it for the third time. I think your plan was perfect, and I would do exactly the same thing.
Obrigada.
Isso aí.
E isso que a Ana Paula falou...
Diga.
Desculpa. De que a gente tem que trabalhar junto, né? Trauma, cirurgia e emergência. E a gente também tem que treinar junto, né? Trabalhar junto e treinar junto. Esse ano a gente começou uma experiência de fazer os treinamentos de simulação de trauma, juntando no meu hospital também não tem cirurgia do trauma. A gente tem alguns cirurgiões que são cirurgiões do trauma. E a gente juntou os treinamentos com a residência de cirurgia, a residência de emergência e os staffs. Então, assim, tá sendo muito legal. Acho que foi a melhor experiência de todos até agora. E isso, a gente treina junto, né? A gente enxerga um ao outro e aí a gente começa a ficar mais fácil para trabalhar junto. Então, assim, tá sendo muito legal. Acho que o primeiro passo, esse foi um conselho que o Gibbs me deu, né, no nosso programa de residência. A gente estava tendo muita dificuldade de ter essa integração. E aí, se a gente se escuta, né, cientificamente falando, um aprende com o outro, né? Então, o residente de cirurgia da aula, o residente da emergência da aula, a gente discute junto, né, o atendimento, e aí a gente entende que a gente está fazendo pelo bem do paciente. Realmente, a chance da gente trabalhar junto aumenta muito, assim, bem, né? Muito bom.
Sim, melhora, né, o atendimento do paciente.
Os residentes ganham, os pacientes ganham. Acho que é benéfico para todo mundo.
E o ideal ainda seria fazer reuniões com a enfermagem, né, gente? A gente sabe que seria o mundo ideal é a gente conseguir que a equipe multi toda esteja sempre na mesma página. Isso na emergência é uma realidade total, assim. Mas, enfim, fazemos o que dá para fazer. Vamos passar para a aula. Vocês acham que já tem mais alguém que quer fazer mais algum comentário? Senão a gente já passa para a aula direto. Nós vamos falar sobre trauma de face hoje com o Dr. Gibbs. Podemos passar? Então, vamos fazer isso. Eu tinha falado já no início, né, para a Jule, eu às 9 horas tenho um compromisso familiar, então eu vou ficar esses primeiros 15 minutos, eu acho que talvez eu não consiga ficar até o final da aula, mas eu vou, enquanto eu puder ficar aqui sentada, não vierem bater aqui na porta e me raptar, eu vou ficar aqui. Tá, Dr. Gibbs, então, muito obrigada novamente, Larissa, pela tua apresentação. Eu vou passar, então, a palavra para o Dr. Gibbs para nos dar a parte mais teórica dessa aula. Obrigado.
Muito obrigada, foi um prazer participar.
Prazer te receber. Talvez tu tenha que tirar a tua apresentação, Larissa.
E agora, share screen. Ok, podem ver a minha tela agora?
Sim.
Okay, so I'll switch over to English. And again, I just want to thank Larissa for an outstanding presentation. We know that it's for you to get up in front of a large group of maybe some strangers or people that you know, but some strangers, it takes a lot of courage, but I know that emergency medicine in Brazil is very courageous, so thank you for being a pioneer and helping us advance your specialty. I'm extremely proud of all the residents on this call. This is my best activity of the entire month, to be able to meet with you and talk about trauma care. Just as a reminder, I work in Charlotte, and we work in a busy trauma center. We're the 5th busiest trauma center in the United States. This year is fun for us because our residency program this year is 50 years old. It's one of the oldest programs in the country, and we see about 120,000 patients a year. I live in Charlotte, North Carolina, which is on the east coast of the United States, and the reason that a razão por que eu estou aqui é que quando eu era pequeno, eu vivi no Brasil. I lived in Brazil for 5 years in Rio, and traveled to many parts of Brazil. I'm very proud that I got to do that as a child, and now 50 years later that we get to reconnect and talk about trauma. Again, this project that began some years ago, the goal of this project is to provide a practical, evidence-based approach to trauma care that is dedicated to the emergency physician. Our outstanding case presentations continue, and we will have lectures and group discussions. The curriculum will be in place we'll have a 2-year curriculum. And again, the highlight of every month, as we saw today, is to present your outstanding cases. And what we know is that the care of trauma in Brazil is outstanding, and we look forward to working together to continue that trend. Now, with regards to facial trauma, what we're going to talk about today is resuscitation. I'm also going to spend quite a bit of time on the physical exam, because I think it's very easy. I can order a CT scan of the entire body in 5 seconds in the ED, but I think the physical exam is very important, especially when it comes to assessing function of the face. We'll talk about imaging, and then we'll talk about some management and consultation. If you look at the epidemiology of facial trauma, it varies. The 2 highest populations are vehicular trauma, so motor vehicle crashes, but assaults, especially in large cities, assaults are a very common cause of trauma. And now with the aging of the population, for example, I'm almost geriatric, falls in the elderly become a big cause of trauma. And also remember that in women, not only women, but especially in women, we always need to think about abuse and interpersonal violence. So we should always ask our patients about this. And if you look at large trauma centers, for example, where I work, about 10% of our patients will have significant maxillofacial trauma. If you look, and some of this may be for your exams, if you look at facial fractures, we know that number 1, 2, and 3, number 1, nasal fractures are the most common, followed by mandibular fractures, followed by zygomatic arch fractures. And if you work at a trauma center, we're going to see patients like the one that Larissa talked to us, where we have significant mid-face trauma and orbital fractures in larger referral centers of trauma. This, as in your case, remember that our patient that Larissa talked about had subdural hematoma, epidural hematoma, and facial trauma. And as you can see, this study looked at a very large population of patients, almost 500,000 patients. And you can see here that especially facial trauma and head trauma, they tend to be companion injuries. And to a lesser extent, you can also have injury of the spine, not big numbers, but it's very important because of the force vector to also think about the spine in patients that have facial trauma. If you have a patient who is alert and able to provide a history, there are a number of questions that you should ask them. Where do they have pain? Where do they have numbness? Are they able to breathe? Are they able to swallow? Does their bite feel normal, especially with mandibular fractures? Do they have pain with mouth opening? And then their vision is also important to assess, because we know that with facial trauma, we can have ocular injuries. And of course, as we talked about, do they have cervical pain or tenderness? When you're looking at the face, it's very important to assess for symmetry between the right and the left, to look for areas of ecchymosis and contusions that may reveal an underlying fracture or soft tissue injury. And I would really encourage you to palpate the face carefully and to look for step-offs, for example, at the base of all lacerations. And then when it comes to function, you want to assess the facial nerve, you want to assess facial sensation, eye movement, pupils, pupillary function. You want to assess them for an afferent pupillary defect and the ability to open the mouth. For example, when we look at this patient, this is a patient who was in a car crash. When you look at him from the front, he may appear to be relatively normal, but when we look at him from the side, you can see that he has a mid-face fracture with significant depression in this region where he has fractures behind the orbit, and this part of his face is pushed backwards. And you may not fully appreciate that if you look down on him from above, so making sure that you do a good exam is important. When it comes to the eyes, remember that you have soft eyes inside hard bones. So the position of the eye and the lids and your ability to examine the orbital rim is very important. Make sure that you test ocular function and eye movement, and also look for an afferent pupillary defect. Here, for example, this is a classic picture of a patient who is asked to look towards the ceiling and is unable to look up with the left involved eye. And this is a classic finding that you'll see with an orbital floor fracture, where the inferior rectus muscle is trapped and prevents upward gaze. So having the patient move their eyes and watch their eye movement is very important. Here's a patient that has a hyphema, and remember that these can be vision threatening. So making sure that you do a good eye exam. That may be very difficult if the patient has massive facial swelling. So you need to open the lids, either using some surgical tools or your hands, or a second provider to be able to open the eye and inspect the pupil and look for hyphemas, and also look for things like this, which would be a ruptured globe. So careful inspection of the globe is extremely important in the patient with facial trauma. What we see here is a medial canthus injury. So whenever you have a laceration or blunt force trauma to the medial aspect of the orbit, make sure that you consider the canthus as being affected. So again, hyphemas, orbital rupture, etc. When you look at the nose, you want to look for symmetry, bleeding, and also be careful to look for CSF, rhinorrhea, and a septal hematoma. And here you can see, in this particular picture, you have a clear nasal fracture with deformity of the nose towards the right. Remember that when you have this particular injury, those injuries need to be managed usually within 7 days. So if this patient is going to be discharged, they need to have prompt follow-up, so that can be managed. And here you can see, if you look at this patient's nose, this patient has a septal hematoma, which is bleeding around the septum of the nose. If these are not addressed, what can happen is you can have necrosis of the septum, and that can cause permanent deformity of the nasal structures. When you look at the mouth, again, you should watch, like in Larissa's patient, we want to watch the patient's ability to swallow and handle secretions, especially when they are flat on the stretcher and they can't, for example, they can't clear their airway easily. So make sure that you assess their ability to swallow, also the stability of the tongue. I'll show you an example in just a moment. And then look for mid-face signs of mid-face instability, and make sure that you do a careful intraoral examination. So again, putting your fingers in the mouth to assess whether or not the patient has fractures of the alveolar ridge or of the mandible is really important. And also looking for mid-face instability. This exam, I think this exam is helpful, but you may actually have a mid-face fracture or a fort fracture without frank instability, especially if they have a lot of edema. So your exam may not be completely sensitive. And then remember that you can have dental injuries. We in the US, we use something called the Ellis classification. Remember, an Ellis-1 is a fracture through the enamel, and Ellis-2 is a fracture through the enamel and the pulp. Ellis-3 goes all the way into the dentin. Into the second one is dentin, and the third is for the pulp of the tooth. So making sure that you inspect the teeth to look for fractures is also important. And this is a patient, when I talked about tongue stability, this is a patient we took care of who had bilateral mandibular fractures, and he was in a collar. He was intoxicated. He was supine on the stretcher, and the problem is because he had no mandibular support for his tongue kept falling back into the airway and occluding his airway. So we actually had to put a stitch into the tip of his tongue with a little bit of anesthesia, so we could pull the tongue out of his mouth so he wouldn't occlude his airway. So especially bilateral mandibular fractures, you may lose stability around the tongue. When it comes to the airway, we've already talked about this, and I think Larissa did a fantastic job of describing some of the challenges. And simple maneuvers like patient positioning may be important, and also getting the tongue out of your way, making sure that you have good tongue control and that you have good suction to control bleeding. I would say that generally, if you have significant mid-face trauma, you want to avoid what we call supraglottic airways or blind insertion devices. I would not say never, but unless you have a very good sense of where the injuries are, I would not put in a blind device unless I'm very secure that I'm going to be able to access the airway without causing additional damage. I think we like to think about endoscopic techniques, but those can be challenging if patients have active bleeding. We have already talked at length about a double setup, and I would say always identify the cricothyroid membrane. And Larissa talked about ultrasound. Remember that generally in an adult patient, the cricothyroid membrane is 4 finger breadths above the sternal notch. That gives you a sense of where to find it. Okay, then with bleeding, I would say direct pressure, packing if needed. You want to avoid clamping in wounds, and fracture reduction may be helpful. And here in our hospital, in patients with significant bleeding in the setting of facial trauma, we will mobilize our angiography team early to perform angiographic embolization. And this is a patient, for example, that had mid-face fractures and a Lefort injury that had significant epistaxis that required endotracheal intubation for airway protection, as well as bilateral packing of the nose to prevent continued bleeding. And when it comes to life-threatening hemorrhage, fortunately, these are uncommon. If you look at a large population of facial fractures, only a few % will have life-threatening bleeding, and most of these are significant mid-face fractures, specifically Lefort injuries, and we're going to talk about those in just a moment. And this just shows you a patient who has, this is an angiogram, a vascular angiogram of the face that looks at the external carotid artery where you have a contrast blush or extravasation of contrast, and here is a post-coil embolization with the coils placed here. So I would say early mobilization of angiography, if you work in a center that has that technology available, can be helpful to you. And I'll skip this slide. Now moving on, I'm going to talk about some specific facial fractures and imaging. I would say that when I was in training, we used plain films a lot. So before CT scan was widely available, we used plain films, and typically it was these three. You can see what's called a Waters view that allows you to see the posterior orbit, and a Caldwell look, which is really an AP view that allows you to see the nasal bridge and the inferior orbit, and then what's called the submental vertex will allow you to see the zygomatic arches. I would say that this is more information for museums, and unless you work in a resource limited population where you don't have CT scan, because we know now that CT scan is by far the most commonly used study to reliably assess injuries. Let's talk about the specific injuries now. Again, the most common fracture of the face are nasal bone fractures. These are very, very common, and they can occur from a bunch of different mechanisms. If you look at this study of a large population of nasal bone fractures, they tend to occur in the young, and in the elderly patient, they tend to occur due to falls. In young patients, a lot more related to assaults or car crashes. So again, this is the most common facial fracture, are fractures of the nasal bone. Typically, this is a clinical diagnosis, and you're going to look for swelling and deformity. You want to always make sure that you assess the patient for a septal hematoma, as I talked about. You may have some work to do with hemorrhage control that may require some packing. And if the patient has a gross deformity of the nasal bridge, make sure that the patient can get referred within 7 days. They typically are not going to be fixed right away. They don't need to be admitted to the hospital. Once you've ruled out a septal hematoma and the patient has adequate referral, our plastic surgeons will typically like to see them within 72 hours so they can do operative planning. And again, here's an example of a nasal fracture right here in this particular patient, that you can see some deviation of the nose there. Here's the use of ultrasound that's also been described to assess for nasal fractures. And here's the nasal bone right here. This is in the same patient, plain films compared to ultrasound. And again, the septal hematoma right here in the right near. If you have this, remember that you need to do incision and drainage. either with a scalpel or with with a large bore syringe, and then the nose can be packed. And what I would typically do before doing this is I'll do some kind of facial block. I'll usually use an supraorbital block and an infraorbital block together. We'll show you those blocks in just a minute so you can have good anesthesia of the nose. Now, there's another type of injury that's more significant where you have combination injuries, not only of the nasal bone, but also of the orbital and ethmoid. So the entire intraorbital area is fractured. These areas are much more significant and have a much higher complication rate. So it's very important for you to be able to distinguish with diagnostic imaging a simple nasal fracture compared to what's called a nasal orbital ethmoid fracture. And these involve the nasal bridge and the ethmoid in the medial orbital wall, and they can cause significant pain with eye movement or limitation with eye movement. These patients typically will have a lot of epistaxis, and they oftentimes will have CSF rhinorrhea, although this is going to be difficult for you to evaluate in the emergency department. And the assessment of these really has to do with the medial canthal ligament and whether that is stable or unstable. I'll just show you here. So these are 3 different examples, and we don't need to know this classification system by heart, but I do think it's important to be able to distinguish nasal orbital ethmoid fractures from simple nasal fractures. And they're going to have a lot more inflammation. They're going to have more injury to soft tissue and more epistaxis. We'll talk about frontal bone and sinus fractures. Again, these can result from a direct blow. They can result from striking your head on the dashboard of a car. They can result from a fall with a direct head strike in the elderly. And there is a significant association between frontal bone fractures and injuries to the brain as well. Again, you want to assess for swelling. You want to be very sure that if the patient has forehead lacerations, that you palpate those carefully to make sure that there's no bony step-off within the laceration. If they have subcutaneous emphysema, that can be an important clue that they may have a frontal bone fracture. And again, this particular case, what you see here is the frontal table, the frontal portion of the anterior table of the frontal bone is here, and the posterior table of the frontal bone is there. If you have only the anterior table, these patients are typically managed by either plastic surgery or ENT. If you have a posterior table fracture, these typically involve neurosurgery because you have penetration in the calvarium, and you can see a little dot of pneumocephalus right there, a little bit of air in the brain. So distinguishing a frontal table from a posterior table fracture is really important. And again, depending on whether the brain has been violated, that will tell you whether or not you need to get neurosurgery involved. I would say generally, many of these patients will receive antibiotics, but the literature actually, the more recent literature would say that antibiotics generally don't improve outcomes in these patients. So rather than timely surgery. We're going to talk about the orbit and the orbital fractures because these are very common in emergency medicine, often from direct blows or falls or motor vehicle crashes. And I just show you this slide because the anatomy is complicated, and you have in the orbit itself, you have several different facial bones coming together that will articulate in the back of the orbit, and also you have a lot of vital structures there that not only that control vision, the optic nerve, you have vascular structures, and also you have all of the muscles, the nerves that control eye movement. So the orbit is, I would say, high risk territory because of all the structures that are there. The most common fracture of the orbit is called an orbital blowout fracture or an orbital floor fracture. And what happens is the blunt force is transmitted to the base of the orbit that is the weakest and thinnest part of the orbital structure. And these can sometimes be associated with significant globe injuries. And we're going to look at some of those. These patients may have, as your patient had, periorbital ecchymosis. They may have diplopia or limitation of upward gaze. They may also have infraorbital anesthesia if the infraorbital nerve is involved. And they may have, if there's a hematoma behind the eye, they may have exophthalmos or enophthalmos if the eye drops into the orbit. So again, when the force is applied to the front of the eye, the force is transmitted to the back of the orbit or in the inferior floor. And this is the weakest part of the orbit So the fractures will typically be inferior, and you may have movement of intraorbital contents into the orbital floor. And again, like we saw earlier, this patient has a left orbital floor fracture, so he will have limitation of upward gaze because of entrapment, usually of the inferior rectus muscle, but it can be other structures that can also be drawn down into the maxillary sinus. And here are several examples of orbital floor. These are all different examples. I like to look at the coronal views of the face, and these are 3 different examples of fractures of the orbital floor with a little bit of herniated material. Another example here, and another example here. Also, a clue may be a patient that has blood in the maxillary sinus. That may be a clue to you, but they may also have an orbital floor fracture. So remember, very common. The force is transmitted again to the front of the eye. The force then goes down into the weakest portion, which is the floor of the orbit, and you can have a fracture in the orbital floor. Usually, these patients, when I was a resident many, many years ago, these patients would often get admitted to the hospital to have repair of their orbital floor. Now this work is all done as outpatients. Again, the use of antibiotics, I would say, there really is not great evidence that antibiotics improve outcomes. And you want to make sure that you instruct the patient, if possible, to avoid blowing their nose so they don't push air into their fracture segments. Okay, and then remember that traumatic diplopia, there can be many things in play. Not only can they have entrapment of the inferior rectus, but they also can have a lot of other injuries. So make sure that you do a very careful ocular exam, that you look carefully for things like lens dislocations and hyphemas and orbital rupture, as well as injury to the extraocular muscles. And we're going to talk about those in just a minute. Again, the medial wall also is very vulnerable. This is called the lamina propria, where you have a medial wall fracture. Instead of the orbital floor being fractured, you have a medial wall fracture. And here you can see a fracture here of the medial wall versus the floor, because this is also a very thin bony structure. It's called the lamina propria, and the same type of mechanism where you have a force that's transmitted here into the medial wall of the orbit. Again, these patients will present sometimes with diplopia. They may have epistaxis. They're going to have a lot of swelling around have a lot of subcutaneous emphysema, and the mechanism of injury is relatively similar to orbital floor fractures. And here's another example of a medial wall fracture right here, another one here on the axial views that shows the fracture of the medial wall. And these are going to be fixed as outpatients with appropriate consultation. Here's another one that shows a lateral wall fracture instead of a medial wall fracture. And we can see here the fracture through the lateral wall of the orbit. This patient is pretty similar to Larissa's patient, where you have multiple facial fractures involving the mandible, involving the maxilla, involving several portions of the patient's orbit. When you have this type of fracture, you may actually see that the eye may drop down because you lose support of the eye laterally. And the globe that you may, when we're assessing the patient for symmetry, we may have loss of symmetry because one eye may drop down when you have a lateral orbital wall fracture. And these patients, this is the same patient. This is our patient here. You can see very extensive injury to the midface and also the lateral orbital wall. And here's the patient's CT scan after reconstruction, where you have multiple plates that are placed across. These are done intraoperatively to repair the structures around the orbit, and in this case, the mandible. And a reminder here that you have vital structures here that are going across the posterior orbit that include not only the optic nerve, they also include the nerves that innervate the extraocular muscles and allow for eye movement. So this is a very, very sensitive area when you have any fracture of the posterior orbit, and you can have different syndromes where you may have ophthalmoplegia, you may have loss of function of the extraocular muscles, and you may also have blindness, obviously, if you have an optic nerve injury. So doing a careful exam is extremely important in these patients, to look for ocular function, to look at the function of the pupils, to look for eye movement, and also to look for anesthesia of the face. Orbital hematomas are also very important for us to be able to diagnose early, because we know that over time they may cause compression of the optic nerve, and they may cause visual impairment over time. And you should consider this in any patient who has significant proptosis. And I would say that in the US, it is within our scope of practice, and it should be also in Brazil, for you to be able to do a lateral canthotomy, where you're essentially cutting the crux to the lateral canthus, and you actually release the eye if there's a significant orbital hematoma that's pressing on the optic nerve and cause impaired eye function. To be able to release that, remember that there are two different branches of the lateral canthus, and what I'll typically do is anesthetize this directly. You can also do a supraorbital, infraorbital nerve block to help with anesthesia. Make an incision to the lateral aspect of the soft tissue near the orbit, and you want to reach down and cut the inferior canthus to perform a lateral canthotomy. Tripod fractures, again, these involve typically the arch of the maxilla. These are also very common. This can occur from an assault and a direct blow to the side of the face, or from other mechanisms like motor vehicle crashes or motorcycle crashes. And they're called tripod fractures, but they actually involve four bony structures and four articulations of the face. So these tend to be very complicated fractures, and the patient may have difficulty with mouth opening. They may have a significant flattening of the face. They may have diplopia if eye movement is impaired, and they may also have paresthesia of the face if the infraorbital nerve is involved. Now, Lefort fractures, these are important for you to know for your exams, and these basically there are three different classifications for Lefort fractures: a type 1, a type 2, and a type 3. And how I remember these is when you go in this direction, these are more severe. So a type 1 is less severe, and it involves really, you separate the maxilla from the face. A type 2, which actually goes up into the top of the nose and comes down, that's also called a pyramidal fracture, because it looks like a pyramid, that it goes up and down like a pyramid. And a type 3, where you have complete craniofacial dissociation, where the face and the brain are disconnected from each other, and you can actually move the entire face. And sometimes you may have a combination. So for example, you may have a type 2 on the right and a type 3 on the left. These injuries are very morbid. They have a very high rate of intubation. They also are, remember when we talked about life-threatening hemorrhage, these are the most common fractures that cause life-threatening hemorrhage in the patient with facial trauma. So mobilizing your trauma colleagues in angiography also can be really important in these cases. They're very high energy, and the patient may have swelling. The face may be sunken, they go backwards. They typically have a very high rate of bleeding and epistaxis, and also eye injuries are very common when you have Lefort injuries. And here are a couple of examples on the coronal view here. This is a combination injury where you have a Lefort 1 on this side and a Lefort 2 on the left. So coursing down above the maxilla, so Lefort type 1, and this one that goes up towards the orbit is a Lefort type 2. Here's another one where you have very significant disruption of the entire midface, where you have fractures that course all the way from here across the face, over the top of the nasal bridge and out the other orbit. And this would be a Lefort 3, where you have complete craniofacial dissociation. And this patient, of course, was intubated immediately upon arrival because of the massive facial swelling. And I would say in this particular case, as Larissa showed us in her patient, securing the airway early is paramount to avoid worsening swelling and loss of the airway. Remember that the cervical spine must be protected because of the risk of cervical injury as well. And I would say rapidly defining your other injuries is also vitally important. So mandible fractures, I think these are common in emergency medicine. And we'll talk about these in a little bit more detail. And here's a patient. This is a young patient who recently came to our hospital, who was unrestrained, and he hit his face on the steering wheel. And you can see here that he has bilateral fractures of the mandible. So the force was delivered anteriorly, giving him a fracture of the angle of the mandible on the right and the angle of the mandible on the left. And the mechanism of injuries here will be different. Important for you to know that there's different classification systems, and I'll review this in just a moment with you, but you have fractures of the symphysis. If you have a fracture here, that's called the parasymphyseal or next to the symphysis. You can have body fractures, angle fractures, ramus fractures, condyle fractures, or coronoid fractures. And these are very, very common in the emergency department. As we can see here, these tend to be injuries of the young, and they typically are the result of either vehicular trauma or assaults, are the most common in the US, followed by falls, especially in the elderly, causing mandibular fractures. We also know that in women and men, this is a large database. In women and men, they tend to have different mechanisms. So in men, assaults are more common in the male patient, and in women, the most common causes of mandibular fractures are actually motor vehicle crashes compared to men. So assaults in men predominate, and then vehicular trauma in women. And again, you can see here that the different distribution of mandible fractures is variable. I'm going to show you several different examples. Now, when it comes to the physical exam, remember that a couple things. The mandible is a ring. So I think about it this way. So all of the vertebral bodies are rings. The mandible is a ring. The pelvis is a ring. So when you have a ring, it almost always breaks in two places. So in about half of cases, mandibular fractures are going to be multiple. And these are some clinical findings that you may see. You may see a number of things here. And if you see a hematoma underneath the tongue, that's actually pathognomonic for a mandibular fracture. So if you look in the mouth and they have a sublingual hematoma, that patient has a mandible fracture, and that's pathognomonic. They also have malocclusion, in other words, inability of the teeth to come together. They may have trismus and limited mouth opening. You may also have mental nerve paresthesias if the mental nerve has been contused. And there's something called the tongue blade test that I'll show you in just a minute. So again, here, testing for mandibular fractures, you need to test both sides. If you have the patient bite down on a tongue blade and you try to break the tongue blade with your hand, or you can have the patient do it. If the patient is anxious about having you do it, you can have the patient do it. And there are several studies looking at the tongue blade test, including one that was recent, that showed that if the patient has a normal tongue blade test or a negative tongue blade test, which means that you're able to break the tongue blade when you twist it, that has a very high sensitivity and negative predictive value for mandibular fractures that is above 95%. So that this can be a very useful test in the patient. Again, you want to do it on the right and then on the left, and you need to check both sides because they can have unilateral disease, and you need to test both sides accordingly. And here again, we talked about tongue support earlier, making sure that that the patient is not going to be aspirating their tongue if it falls back into their mouth. So this patient, if I were to tell you that this patient was assaulted and punched by an assailant, you actually know from looking at this x-ray, is the patient right-handed or left-handed? I can tell you that this is a right-handed patient who punched the patient right here with his or her right hand, and you have a parasymphyseal fracture on the left and an angle fracture on the right. So this can actually help you understand the mechanism of injury. Again, if this is an assault case, right-handed assailant, the patient is struck here, fracture that's parasymphyseal or next to the symphysis, with an angle fracture on the right. So left and right. Here's another one. This is a right parasymphyseal fracture. This patient actually struck his face on the steering wheel, and you can see here that the fracture line goes right down next to the symphysis. Here's another one here. If this patient was assaulted, this is the reverse. A patient who was assaulted by a left-handed assailant. So the patient is punched right here with the left hand of the assailant, and you have a left parasymphyseal fracture and right parasymphyseal fracture and a left angle fracture. So this can help you understand the mechanism of injury. This is a patient who struck his face on the steering wheel. He was unrestrained. And here, because it's an anterior force, you have bilateral parasymphyseal fractures, a fracture down here and a fracture down here. And here is the patient. Here's the CT scan in the same patient. And this is the patient's imaging after repair of a bilateral parasymphyseal fracture. And again, you can also see here bilateral angles and in the same patient. And again, after repair. Another one here where you have, again, parasymphyseal fracture on the left and an angle fracture on the right. So these tend to be companion injuries. This particular injury, a condyle injury, is more difficult to diagnose. These can be difficult to see on CT scan. So especially if you have a patient that was struck right in front of the ear or right on the upper surface of the mandible, you need to think about a condyle fracture. And I would just say, be careful when you're examining your CT scans to make sure that you inspect here, especially in a patient that has lateral facial swelling and limited mouth opening. You should think about a condyle injury. As far as mandibular dislocations, these are common in the emergency department. And remember that these can occur not only traumatic, but they can be atraumatic. And depending on whether they're unilateral or bilateral, that will affect your physical exam. When it comes to relocating these, again, I will typically do a little bit of sedation. You can also inject the temporomandibular joint with some lidocaine. And remember that you need to pull the mandible down and then lift it up in the front. So you need to pull the whole thing down with your fingers on both sides. And then if you lift the front of the mandible upwards, you'll be able to push the condyle back where it belongs. And again, this just shows the position of the fingers. You're putting the fingers on both of the molars on the right and the left, and you're pulling down and then tilting the front of the mandible up to make sure the condyles can go underneath and you can have a relocation of the mandible. Now, as far as mandibular fractures and what's blunt cerebral vascular injury, remember that these are the result of, you need to think about the cerebral vessels in patients that have high velocity mandibular fractures. So if somebody punched me, Mike Gibbs, in the face, you don't need to worry about blunt cerebral vascular injury. But if I'm in a car crash and I have a mandible fracture, or if I fall out of a second-story building, then we need to think about the mandible. So again, this classification system refers to high-velocity mandible fractures. We're going to quickly go through this and look at some soft tissue injuries. I just want to remind us that you can use regional anesthesia it could be your ally. And if you draw a line down the pupil, you have the supraorbital, infraorbital, and mental nerve. And if you're doing repairs of the face, becoming skilled at doing regional anesthesia of the face is very, very important. This just shows that we'll do this very, very quickly. A supraorbital nerve block, and again, the line is down the pupil that goes all the way down here. And then the infraorbital nerve, I will usually go through the mouth and put some anesthetic in the mouth and then go through the mouth into the top of the maxilla. And then for the mental nerve, I will go through the mouth and go down. So this is going to give you the excellent ability to obtain complete facial anesthesia to be able to do good repair. This is a patient who he was on a boat and he ran into a dock and has a deep laceration of the upper lip. And we did bilateral infraorbital nerve blocks to repair his face and to just suture everything back together. This is a patient who hit his face on the steering wheel. This would be a good case for bilateral mental nerve blocks. And this is a patient who was bit by his girlfriend. She bit out a piece of his face. And in this case, we did a mental nerve block and an infraorbital nerve block to have complete anesthesia of the face to be able to irrigate that laceration and do primary repair. Going to talk briefly about we're almost finished. A couple of injuries. Remember that the parotid duct can be vulnerable if you have trauma anywhere between the front of the ear and the upper aspect of the upper lip. So you want to make sure that you don't see saliva in the wound. It's going to be very difficult for you to see. But more importantly, if you open the mouth and you see blood in the salivary duct, in Stenson's duct, you need to think about a laceration to the parotid duct. The facial nerve can also be injured. So make sure in a patient with a laceration like this that you do a full exam of the facial nerve to make sure that none of the branches of the facial nerve are injured. And we already talked about the nasolacrimal duct. If you have a medial canthus injury, this is going to require repair by an ophthalmologist. So those are very delicate repairs. And then lastly, as you know, when you have blunt force trauma to the pinna, you can have a hematoma, and these need to be drained in the emergency department. Or you develop in English what we call a cauliflower ear. This is a permanent deformity from scarring of the cartilaginous structures of the pinna. So make sure that you do incision and drainage. So here what we'll do is we'll do an ear block. So you do a ring block of the ear, And then you can do, this is a patient that we manage with incision and drainage of this hematoma here with a small incision, and then irrigation of that wound. It can also be done with an 18-gauge needle. So we went quickly through a bunch of different injuries. I'm going to stop there and just pause for any additional questions.
Excelente. Eu absolutamente amo essa aula. Ela é maravilhosa. Traz, assim, uma quantidade de coisas que a gente precisa saber, assim, tão, de uma forma tão acurada, né? E tão didática. Então, excelente. Muito obrigada.
E eu vou mandar essa apresentação para a Jule, ela pode distribuir um PDF da apresentação e eu mando hoje, e você pode fazer o que você quiser.
Muito bom. Se alguém tiver alguma pergunta, a gente pode fazer aqui no chat. Gustavo, agradecendo. Muito bom, muito obrigada pela presença de vocês, Nayara também. Muito bem.
So Julie, I'll just say something to all the residents on the call is it's great to see Marina again. Thanks for dialing in tonight, and Niara, really appreciate that. And Marissa and I were in the ED today. I just came home. We had a fantastic time. Laura was there as well. And we talked a lot about the journey of emergency medicine, and I will always talk about this at the end. Remember that you are on a journey, and emergency medicine in Brazil is developing so quickly, and you have a tremendous opportunity to be pioneers of your specialty. And I know that it's difficult sometimes when a specialty is young and growing, but I will tell you that it's very important for you to continue to learn as much as you can. I would say learn more than they expect you to know, right? Learn more than the specialists expect you to know, and keep working hard, and it will be worth every minute, every hour, every day, every month of your hard work to drive emergency medicine forward. And it's very exciting that really you are the future of emergency medicine in Brazil, which is incredible, right? If you think about that for a second. So congratulations on what you're doing. Always a huge pleasure to come. It's my favorite day of the month.
Muito obrigada. Muito obrigada. Tá sendo também uma experiência muito boa para mim, e eu tenho aprendido tanto sempre. E, assim, acho que a coisa mais legal de aprender é realmente as experiências, os outros hospitais, as residências, conhecer as pessoas, isso está sendo muito legal. Como eu falei, esse espaço foi criado para os residentes, é claro que todo mundo é bem-vindo. Nós tivemos internos que ficaram inspirados pelas aulas e viraram residentes, isso também é. E todo mundo, staff, preceptor, claro, está todo mundo sempre muito bem-vindo, pessoal da cirurgia do trauma, mas o espaço foi criado para residentes, então, assim, é importante que vocês participem, que vocês se incentivem a participar, para prestigiar os colegas, e a gente fica muito feliz com a repercussão, com o feedback. Podem mandar e-mail para a gente também com sugestões. Se você quiser apresentar um caso, manda e-mail para a gente se organiza. E é isso. Então, acho que vamos encerrar aqui por hoje. Muitíssimo obrigada e até o mês que vem.
Larissa, muito obrigado outra vez pelo seu caso excelente.
Eu que agradeço, uma honra poder participar desse momento com vocês, gente. Muito obrigado.
Até o mês que vem.